Welcome to MedAura. In this video, we take a detailed look at two opposing classes of drugs that regulate blood clotting, coagulants and anticoagulants. Blood clotting, or hemostasis, is the body's process of stopping bleeding after an injury. It depends on a sequence of clotting factors that activate one another in a cascade, ultimately converting fibrinogen into fibrin, which forms the mesh that stabilizes a clot. This system is normally balanced. Clots form when needed to stop bleeding and are broken down once healing is complete. When this balance is disrupted, either by insufficient clotting or excessive clotting, drugs are used to restore it. Coagulants correct insufficient clotting. Anticoagulants correct excessive clotting. Coagulants, also called procoagulants or hemostatic agents, are drugs or substances that promote blood clot formation. They are used when the body cannot clot effectively on its own or to control active bleeding. Coagulants are classified into four main categories: systemic coagulants, clotting factor replacements, local hemostatic agents, and antifibrinolytic agents. Systemic coagulants act throughout the body. The primary example is vitamin K, which is essential for the liver synthesis of clotting factors 2, 7, 9, and 10. Vitamin K is used to treat vitamin K deficiency, which can occur due to poor diet, malabsorption, or prolonged antibiotic use, and it is also used to reverse the effects of warfarin overdose. Clotting factor replacements are used when a patient is missing a specific clotting factor. Factor VIII concentrate is used in Hemophilia A, a genetic disorder in which factor VIII is deficient or absent, leading to prolonged bleeding after injury or spontaneous bleeding into joints and muscles. Factor IX concentrate is used in Hemophilia B, caused by a deficiency of factor IX. Fresh frozen plasma, which contains all clotting factors, is used in cases of multiple factor deficiencies, such as in liver disease or disseminated intravascular coagulation, a condition in which clotting factors are consumed faster than the body can replace them.
Local hemostatic agents act directly at the site of bleeding, rather than throughout the body. These include topical thrombin, absorbable gelatin sponges, and oxidized cellulose. They work by providing a physical scaffold that accelerates clot formation exactly where it's applied. These agents are commonly used during surgery to control bleeding from small vessels or oozing tissue, where systemic drugs would be unnecessary or too slow. Antifibrinolytic agents work through a different mechanism entirely. Rather than promoting new clot formation, drugs such as tranexamic acid and aminocaproic acid prevent the breakdown of existing clots by inhibiting plasminogen activation. These are used in heavy menstrual bleeding, trauma-related hemorrhage, dental extractions in patients with bleeding disorders, and to reduce blood loss during major surgeries, such as cardiac or orthopedic procedures. Coagulants are used across a range of disorders. In Hemophilia A and B, factor replacement therapy prevents joint damage and life-threatening bleeds. In von Willebrand disease, a common inherited bleeding disorder caused by deficient or defective von Willebrand factor, treatment may include desmopressin, which stimulates the release of stored von Willebrand factor, or factor concentrates in more severe cases. In vitamin K deficiency, whether from newborn physiology, malnutrition, or malabsorption, vitamin K replacement corrects the deficiency directly. In disseminated intravascular coagulation, treatment addresses the underlying cause while replacing depleted clotting factors and platelets. Because coagulants promote clotting, their major risk is triggering unwanted thrombosis, particularly deep vein thrombosis or pulmonary embolism in patients who already have a tendency toward excessive clotting. Anticoagulants work in the opposite direction. They are drugs that prevent or slow down the formation of blood clots by interfering with the coagulation cascade. It is important to note that anticoagulants do not dissolve existing clots. They stop new clots from forming and prevent existing clots from enlarging. Anticoagulants are classified into three main groups: parenteral anticoagulants, oral vitamin K antagonists, and direct oral anticoagulants, also known as DOACs. Parenteral anticoagulants include unfractionated heparin And low molecular weight heparins, such as enoxaparin and dalteparin. Heparin acts by activating antithrombin 3, which then inactivates thrombin and factor Xa. Because its effect is immediate, heparin is used in acute settings, such as deep vein thrombosis, pulmonary embolism, acute coronary syndromes, and during dialysis or cardiac bypass surgery. Its major risks include bleeding and heparin-induced thrombocytopenia, a drop in platelet count that paradoxically increases clotting risk. Oral vitamin K antagonists, primarily Warfarin, block the vitamin K-dependent synthesis of clotting factors 2, 7, 9, and 10 in the liver. Because factors already circulating in the blood must first be depleted, Warfarin's effect takes several days to develop, and it requires regular monitoring through the prothrombin time and INR. Its effect is also significantly influenced by diet, particularly vitamin K-rich foods, and by interactions with many other medications, making dose adjustment an ongoing process. Direct oral anticoagulants are newer agents with more selective, predictable action. Dabigatran directly inhibits thrombin, while Rivaroxaban, Apixaban, and Edoxaban directly inhibit factor XA. These drugs require little to no routine monitoring and have largely replaced warfarin for many indications due to their convenience and more predictable dosing. Anticoagulants are used across a wide range of disorders. In atrial fibrillation, an irregular heart rhythm that allows blood to pool and clot in the heart's upper chambers, anticoagulants reduce the risk of stroke caused by a clot traveling to the brain. In deep vein thrombosis and pulmonary embolism, anticoagulants prevent existing clots from growing and reduce the risk of new clots forming, while the body gradually breaks down the existing one. In patients with mechanical heart valves, lifelong anticoagulation is required because artificial surfaces strongly promote clot formation. Anticoagulants are also used following certain surgeries, such as hip or knee replacement, to prevent post-operative clot formation, and in patients with specific clotting disorders, such as antiphospholipid syndrome, which increases the risk of abnormal clotting throughout the body. The most significant risk across all anticoagulants is bleeding, ranging from minor bruising to life-threatening internal hemorrhage. For this reason, each class has specific reversal agents used in emergencies. Vitamin K and prothrombin complex concentrate reverse warfarin. Protamine sulfate reverses heparin. Idarucizumab reverses dabigatran, and andexanet alpha reverses factor XA inhibitors, such as Rivaroxaban and Apixaban. Together, coagulants and anticoagulants represent the two ends of hemostasis regulation. One class
Restores or promotes clotting when the body cannot do so on its own, correcting disorders such as hemophilia and vitamin K deficiency. The other class prevents unwanted clot formation, correcting disorders such as atrial fibrillation and deep vein thrombosis. Selecting the correct agent depends on the underlying cause of the imbalance, the specific disorder being treated, the urgency of the clinical situation, and the patient's individual risk factors. Thank you for watching this video. If you found it helpful, consider subscribing to MedAura for more clear pharmacology-based explanations like this one.